Good afternoon and welcome to the afternoon breakout session entitled 10 Strategies to Mitigate the Risk of Violence in Healthcare. My name is Rebecca Hill. I'm the Director of Patient Safety and Risk Management at UVA Medical Center. And I've had the pleasure of serving as a member of the Planning Committee for this year's Safety Summit. It's now my pleasure to introduce our speaker for this session. Monica Cooke has more than 40 years of experience in the field of behavioral health and substance abuse in clinical, administrative, and executive risk and quality positions. As a seasoned professional, she founded Quality Plus Solutions, LLC in 2006. Her company provides organizational behavioral health and workplace violence risk assessments, as well as risk and quality support for behavioral health facilities, emergency rooms, and acute care settings. She provides legal nurse expert services and is a certified psychiatric and mental health nurse, continuing to work part-time in substance use and mental health inpatient settings. Monica has served in several leadership positions with both risk and quality societies and provides educational presentations at both the national and state levels. She is recognized as an expert in the field of behavioral health risk and healthcare workplace violence. We may have time for one or two questions at the end of the presentation, so feel free if you have a content-related question to put it in the Q&A box. Please join me in welcoming Monica Cooke.
Thank you, Rebecca. It's a pleasure to be here today. I live in Maryland, so I'm not far from you, and happy to be able to present this to the Virginia Hospital Association, as I think this is a topic that has been long ignored or put by the wayside. I think with all the legislation, all the accreditation standards, things that are coming out around workplace violence in healthcare, we're going to have to get a lot better at this. So what I have here is a presentation that really talks about the 10 top strategies that I believe can help mitigate this risk. And kind of for clarity, I want to make sure everyone understands that there is no evidence-based or are evidence-based strategies around how to mitigate this risk. What we do know is that a combination of strategies can help mitigate it. So it's not one thing, it's a collection of various strategies in the organization. So let's go ahead and get started. We'll talk about some of the strategies. To begin, the data that we have on workplace violence is really deceiving. I do risk assessments around the country. I do workplace violence risk assessments as well as behavioral health risk assessments. And I always ask to look at their data. And when I look at their data, the data really are not reflective of the amount of aggression they have. And that would include kind of verbal aggression or, people being scratched or more minor aggression. Typically, if somebody is hurt, it then gets reported. So it really is deceiving overall. So when staff, get injured, they feel like, well, I better do this because, it could be a workman's comp issue or, I need treatment. But if there's no injury, a lot of times the staff feel like it's just not important to even report. Who cares? If I wasn't injured, who cares? What's the big deal? So we're going to talk about what the big deal is, because that's what we need to shift the culture into in healthcare. So let me move to the next slide if I can here. We have it set up a little different than I'm used to. So I think I've lost my pointer. There we go. Okay. So there is a high cost of inaction, and we know this. We know that violence in healthcare causes property damage, a lot of human resource issues. Of course, one of the largest being is staff harm, and then staff being out on workers' comp for extended periods of time. We know that when healthcare workers are victims of violence, they're out at 5 times the rate of other industries. So that speaks to a real retention issue, as well as a workers' compensation issue. It can be a media, public relation nightmare for an organization if there's a violent act, certainly an active shooter event. But if there's kind of constant violence going on in the organization that's less major, it could still get out into the public and reflect on the organization. And then workers' comp claims, and then litigation, which I've been heavily involved in for the last 4.5 years with OSHA against a corporate entity. OSHA has been gunning after this corporate entity that has many, many behavioral health settings across the country over workplace violence issues. So I know all the literature. I'm very much up to date with what's out there. And that's why I know there's no evidence-based practices. The research is slim pickings and is not definitive on how we can mitigate this risk. It does, although, speak to, as I said, that we believe it's more of a collection of strategies as opposed to one thing that we can do in healthcare. So let's talk about those strategies. And this is kind of a picture reflective of, aggression can start early. So, we experience it in all parts of our life, even with our children. So let's talk about the first strategy. So the first thing we want to talk about is the culture. And I think that like any organization, we have to have a culture around this issue. And that's one of the reasons why other industries aren't as affected by this, because they do have a culture. When we go into the airport, we know how to behave. When we go into the stores, we know how to behave. And we know if we don't, what's going to happen. But what I want to speak about is zero tolerance versus intolerance. So zero tolerance is really, in my mind and by definition, zero tolerant, no tolerance, and that the punishments are dispersed the same to everyone that's engaged in that behavior that is not tolerant. So there's no discretion. For instance, a kid brings a little knife to school, boom, automatically suspended for 3 days. So they're predetermined, and it's always meted out. There's always a punishment with zero tolerance. So with healthcare, I really prefer to call it intolerance. We have to be intolerant of this. And that's a quality or state of being intolerant, and understanding that while we're intolerant, it still could happen, but we're very sensitive to it. And we don't dictate a punishment, a straight out punishment for somebody every time it happens. And we really look at how we can be discreet on the circumstances around the event. And I'll clarify that in a minute. All right, I seem to be having a little problem here. Let me get back to where I need to be, sorry. Okay. So the first thing that I recommend, and which a lot of organizations are doing around the country, I like to think it's my original thought, and I think it is, but maybe not, where we post signage that speaks to the culture. When somebody walks into an organization, I do believe that our communities need to be oriented to the fact that healthcare is the highest of any industry. A lot of people don't know that. And when you say that, they go, what do you mean? People aren't hurt there. And they really don't understand what violence means in our setting, or the definition of violence. So I recommend signage. This is a very nice, welcoming type of sign. Did you know that healthcare has the highest rate of workplace violence of any industry? That lets the community know why this sign is here to begin with. And then welcome to our hospital. We expect that everybody is respectful and non-disruptive. And thank you for helping to keep us safe. So organizations have different signage that's much stronger in language. Some are softer, but I think any way we want to do it, we need to get signage out there. The next is very important, and I call it name the aggression. So we need to name the aggression. And what happens when patients are aggressive, and I'm a nurse, by the way, have worked with behavioral populations for well over 40 years. And I think what we tend to do in nursing and in healthcare is we tend to rationalize the behavior away. So for instance, if we have a demented patient who's scratching somebody as they're providing care, we go, oh, well, they're just demented. They don't know what they're doing. Instead of saying, oh, that's aggressive behavior. Now we need to do something. When we name it, we have to do something. So by that, I mean, if we name it aggression, then we have to get the clinical team involved. We have to say, look, this patient's being aggressive. How can we manage the behavior better? How can we keep staff safe with Teflon sleeves? How can we manage this and not just poo-poo it away? And sometimes we do that with lots of other patients in the hospital, just plain nasty patients that are just being mean and nasty. And we go, oh, well, they're just upset because their daughter's sick or their mother just died, or in other words, we blame it on the etiology. So my point is, regardless of the etiology, we have to get staff to name it. And then once we name it, we have to manage it. So hopefully that makes sense to everybody, because if we don't name it, then we ignore it. And we're not intervening how we should be intervening in these circumstances. Lower level aggressive events as well as higher level aggressive events. So I don't know why, but let me do this here. There we go. So the next strategy is leadership safety rounds. And, I do a lot of assessments, and staff routinely tell me that patients have more rights than they do. And I think that we've had quite a large patient safety movement going on for many, many years. But we have not had a staff safety, bandwagon out there. So I think it's time we get on that bandwagon. And when I talk about leadership safety rounds, really that is leaders, that's executive leaders that walk around and talk to staff on a regular basis. Maybe it's once a month, they do the rounds on each unit, or every other month. And they allow staff to talk about their safety. And staff ask questions, leadership ask questions like, how safe do you feel? Do you have any safety issues for you here? Are your patients, do you feel like your patients are going to be of harm to you? Or is there equipment that's not safe for you, or whatever it is, and allow them to talk about their concerns about safety. It's also a time to give reinforcement on what your aggression mitigation practices are. And we'll talk a little bit more about that, and to reinforce incident reporting. So really, we want reports. I'm a risk person. We want all reports of aggression. If a patient yells at a staff, and this is on behavioral health units and the ED, anywhere, if you get yelled at, if you get threatened, anything, we want to know at what rate and in what areas this is highest. We know right now that it's really in emergency rooms and on behavioral health units. So, but we really want to target the areas with the most that need the most attention first, and then move it throughout the organization. It also enables the leaders to identify ongoing risk mitigation strategies. So as they're walking around, they're going to hear things. They're going to go, oh, goodness, maybe we need to put this in place, or our workplace violence committee needs to work on this. So it will broaden the horizon and also have the leaders visible and walk the walk and talk the talk when it comes to workplace violence. So there, okay. So another strategy, number 3, I think, is 1, 2, 3, yeah, assessment and reassessment. And what we know, Joint Commission actually did a drill down of data on aggression events, serious violent events, sentinel events, actually. And what they found out is that assessing the patient is the root cause, the lack of assessment or inadequate assessment of the patient when it comes to this risk. So good strategies for this: initial history of aggression and trauma, and also routinely administering an evidence-based aggression tool, particularly in behavioral health and in the ER. And those tools are out there. A lot of behavioral health units have used them, and large acute care hospitals are beginning to integrate them into their intake assessments of their admissions so that they can be proactive in identifying patients that are possibly at risk for being aggressive. And I have all these tools. I want to let people know if I talk about things, if there's anything that you need, I'll be happy to send it to you. So just email me and I'm happy to follow up. The most common tool is the BROSET checklist, violence checklist. It can be publicly obtained as well, BROSET. We need to routinely assess patients for sign of anxiety and agitation. What we know is that violence starts as simple anxiety and agitation. So if we can get good at recognizing when patients are escalating at the lowest level or getting anxious and intervene at that point instead of waiting, we can mitigate a lot of this risk. And, I use an example of like emergency rooms that are really into emergent care, and they're really not focused on preventative care. And I understand that. And when I need urgent emergent care, I want to make sure they're there for me. But with this issue, we have to get good at being proactive. And that means managing at the lowest possible level. And usually in the emergency room, that means medication. We should be utilizing behavioral health clinicians in the emergency room. If you're not, you need to get them, because those are the people that can work to offset this risk and assess patients to the degree that will allow us to determine all the risk factors and take appropriate precautions. And then the other strategy here is to flag for aggression in the EMR. This is, I believe, going to be a mandated requirement strategy to mitigate this risk down the line. Both OSHA and Joint Commission are on board with this. They've been recommending it forever. And I think that it will soon come down the pike. So if you have not established a procedure for that, established a policy, who puts the flag on, who takes the flag off, you may want to think about starting that in your workplace violence prevention program can work on that, or your committee rather. So the next is protocols for proactive intervention, and we need to begin early. We cannot wait for this. And this is what happens on behavioral health units. We manage every sign of anxiety and aggression. And that's why behavioral health units stay pretty safe for the most part. And if they weren't, staff wouldn't work there. So they are trained to intervene. The issue with this, I think, is that my guess is about 50% of healthcare people cannot intervene. They just don't have it in them. I think that with there's a lot of trauma out there. And when people start getting aggressive, there's a lot of staff that simply pull back, and they don't feel like they can respond to that appropriately. So either they're inappropriate in their response, or they back away and leave and ignore it, basically. So, we have trauma. About 90% of us have some trauma. So when somebody is yelling and screaming in our face or pointing a finger or throwing things, it does bring that trauma up and can make us unable to intervene in those situations. So if that's the case, what we have to do is be fair about this and say, well, we've trained you what to do and you better do it. What we need to say is we've trained you in the protocol, but if you can't do it, then this is what you do. For instance, if the protocol includes, if a patient's yelling at you in their room, you say, excuse me, I'm going to go get somebody. If they can't handle it, or if they don't feel like they can appropriately intervene and de-escalate that, they need to say, hold on, I'll be right back, and go get somebody that can. And then those people, 2 of them, go in and manage the situation and work with the patient to get them to de-escalate and get them to a point where they're more reasonable and safe. This is usually very effective, as sometimes, patients just want to bully and intimidate. So when we bring in 2 people instead of 1, it's a whole different dynamic. The next is debriefing. And, we know debriefing is used by highly reliable organizations, planes that don't crash in the air, and nuclear industries that, they don't blow up. I think that what we need to understand in healthcare, while we might not debrief everything we do like they do in highly reliable organizations, that minimally we should be debriefing things that are harming healthcare and affecting us. And that would include aggression. So anytime there's an aggressive event, even just a patient yelling, if there's a culture of debriefing where the staff that are involved, might just be a couple staff, get together after the event and after it's settled down and do a formal debriefing, and I actually have debriefing tools, formal tools, then talk about what happened, how did it happen, what did the patient look like an hour ago, what did we miss, what could we have done, how could we have intervened, to figure out how we can work to prevent it, not only with this patient, but to build a toolbox on how to prevent it with all our patients. So that's what we want to be able to do. Behavioral health rapid response team, I'm sure some of you have heard about this, and you're familiar, and some of your hospitals probably have them, but these are up and coming. They've been recommended for a long time. It is not the same as a crisis team. We all have security, and when we have a big crisis, we call security. But what's happening now is that in a lot of hospitals, people are waiting until the situation is so escalated they have to call security because they're not managing it at their level. So this is a level down. This is a medical rapid response team. The blood pressure's going up. We can't regulate it. We need some assistance. And so the staff would call somebody. So it could be a team. It could just be a person that has competencies. It could be the nurse supervisor. It could be somebody from the behavioral health unit. It could be anybody or a team of people that are clinically trained and skilled in de-escalation and able to come in and not only help de-escalate the situation, but role model for the staff. So the staff don't get to run away. They come in and they're part of the process. This is what we call just-in-time learning. This is what people need. We don't have time to sit them in the classroom and talk about this forever. They need to see it in action. It is very effective. It works very well, and staff learn, and aggression starts going down. There are many hospitals that use it that have had very positive results. It's very proactive. And it needs to be a 24/7 situation. It can't be, we only have support for you 7 to 3 or 7 to 7. It's got to be 24 hours. And that's why I say, start small, start with the nursing supervisor, start with, whatever resources you have that a nurse or another person that's having difficulty with a visitor or anything like that, instead of calling security, can call somebody with a clinical background that can help manage it. Staff competencies is a topic that we could really spend a lot of time doing. I only have 30 minutes, so we don't have time to do that. But I think that this is a list of all the competencies that are really considered standard competencies. I believe, and a lot of organizations believe, that every staff in the organization should be trained in de-escalation techniques. And that includes non-clinical people, because we have everyone dealing with patients and visitors. There should be protocols for aggression management, just as I spoke about, going to get somebody, getting support. There should be an aggression violence assessment. I talked about the brochette. The staff, from a standard perspective, that should be trained in nonviolent crisis intervention should be security, ED, and I recommend ICU, and then of course behavioral health settings, because they are managing patients that can get quite impulsive and reactive. They need strong competencies in restraint and seclusion. It is a huge liability for organizations. I can tell you, staff are not fully aware of the definition of restraint, definition of seclusion, the federal guidelines. And so if we don't do anything, we should be training every single nurse and provider very thoroughly in the restraint and seclusion federal regulations that go along with Joint Commission. And then they need competency in the workplace violence program. What is your program? Do you have a program? what is workplace violence in your organization? What are they supposed to do when it happens? Who do they report to? How does it work? And again, while these things are not mandated now, my sense is in the not too distant future, healthcare will be required to have these. And there actually are about 9, 10, 12 states maybe that have mandated a workplace violence prevention program and staff education in that arena. The environment of care, we know that about 80% of our risk is in the environment. So if we, and that's from the experts that are colleagues of mine that do design. And I think that this is a list of things that you should do, that should be in place. We should conduct an EOC risk assessment to see where our risk in the environment from an aggression standpoint. There should be secured entrance and exits of the ED. A lot of EDs still aren't secured for egress or exit, but it's very helpful to control the flow. We should identify safe rooms in the ED or on med-surg units or whatever the setting is. In case there is an active shooter event, where should staff go? Where's the safest place for them to go? We should have safely designed rooms for aggressive patients, and there's a whole design for that I can share if you're not familiar with it. Treatment offices should have 2 exit doors. Staff shouldn't have their back up against the wall and be cornered in the room. Those situational awareness concerns that can provoke dangerous situations and cause harm to staff. The next is diversions, and I talk about this because what we do with a lot of patients that are dangerous is we take all their clothes and we put them in a gown and then we put them in a room with nothing to do. And if you did that to anybody, you would cause them to be agitated and aggressed. So what we need to remember is while we need to keep them safe, we also need to keep them distracted. So having distractions, television in the room, they can maybe even use their cell phones, their iPad, music, activities to do. If it's long-term stay in the ED, they need things to do, because if not, they're only going to sit and ruminate, and that'll cause anxiety and agitation. The next is incident reporting and data collection and analysis. And I already told you that our data is not very good with workplace violence. Some places are a lot better than others, but we need to look at the whole realm of data. So looking at just, for instance, your event reporting data is not enough. We need to look at all the data. We need to look at security logs, which often are not integrated into the review of workplace violence, or that's the only thing looked at, and we're not looking at event reports along with that. We need to look at workers' compensation. We need to do surveys for staff. Violence surveys for staff to get their opinions and their input. There should be huddles, or when there's debriefing, we should be collecting data from that. And of course, all of this should flow up to the risk and quality, as well as the workplace violence committee that you have at your organization. Most organizations have it at this point. And the last is a workplace violence committee. So if you don't already have one, and I really honestly believe that this will be mandated in the not too distant future. So if you don't, I would suggest you develop one, and they should review events of aggression. They should develop these protocols that staff should follow. And they should be looking at data and the trends and what do we need to change? What new intervention do we need to put in place? And then they can be the ones to establish the workplace violence prevention program overall for the organization, if you don't already have one. So the key takeaways: it's costly. It's costly to continue to allow it to persist, but it's even more costly to ignore it. Leadership support and rounding is very important. Debriefing, assessment, reassessment, competency, environment of care, diversions, reporting, and a workplace violence prevention committee that actually oversees all the activity. So here's some resources for you. And thank you so much. I know that this was fast and furious, but if I mentioned anything that you want a resource on, or anything I can help you with, I am happy to do that. Just email me at this email, and I will send you what you need if I have it. Thank you so much, everybody. It was a pleasure.
Monica, we do have some questions in the Q&A section.
Okay.
The first one is, in any organization, there is the ethics and compliance hotline for event reporting. Are these ever recorded?
Are the what?
Ethics and compliance hotline.
Yes. What about it is what reported?
I guess are the events that are recorded on the hotline, are they recorded?
I don't, I think each organization is individual. If we're talking about workplace violence events, they
Yeah,
really should be reported through your event reporting system,
right.
right? So risk can manage them, or whoever's managing them, quality, risk, whoever's managing them, not through ethics or compliance, because those aren't ethic or compliance concerns from my perspective. They wouldn't
No.
want that notification.
Yeah, I would agree with you. The next one, any advice on proposing some of these changes to a hospital with inconsistent resources?
I don't think that most of what I discussed as strategies have a lot of fiscal limitations. You know what I mean? I don't think that they cost a lot to do. We talk about just-in-time training, we talk about use of debriefing, we talk about shifting culture. So this comes from the top down, but it really stays in place in the middle. So it's really your managers, your directors that need to get on board and agree that this is where we want to go and to set up your strategy to go there. You may need behavioral health resources if you don't have anybody evaluating patients, but that you should have. Anyway, this population is going to get larger and larger and larger in the ED as well as throughout all the continuums of care. So I don't think that we can go on not having that resource.
Absolutely.
But I think the other strategies are ones that can be implemented, at least at some level in the organization.
Okay, and this question is, yes, I can answer this for you, Monica. Yes, you have some resources that you can share with us, and also your website for like a violence debriefing tool and so forth. And anybody could share policies and procedures that they could, learn from. So
yes, and there are lots of toolkits out there on this topic. And of course, OSHA has done a lot of work and gives a lot of guidance on how to establish a workplace violence prevention plan. It's not mandated yet unless it's mandated by your state. I don't think Virginia has that mandate though. I don't think that you might, but I don't think that you do.
yeah. Well, I think that's all the questions we can get to for the session today. Jennifer?
Okay.
All right. Thank you, Monica, for a great presentation. So we will now end this session and provide our attendees a few minutes to transition to their next breakout session. Thank you, Monica.
Thank you so much, everybody. Have a good rest of the session, the summit.
Yes. Thank you,
All right.
Monica, and Rebecca too. Thanks.
Okay. Bye-bye.
Bye.